Nilesh, over to you.
Thank you so much, sir. And sir is always kind with his words, his praises, and I don't deserve much because everything I am today, I am because of him. So a big thanks to AIOS Scientific Committee and Ashish sir for giving me this opportunity. I'm going to talk about, we will talk about how to understand immunogenicity in the eye. So these are my financial disclosures. So we already know that immune response is a sequence of molecular and cellular event intended to get rid of the host of a threat, offending pathogenic organism, toxic substance, cellular debris, or neoplastic cell, which may be either innate, that is from inside the eye, or inside the body, or adaptive. Inflammatory response, theoretically, is a clinically evident immune response. So understanding the ocular immune privilege, which means the loss of immune response in the eye, has developed over time. First described in 1950, Medawa described immunologic ignorance to be based on passive mechanisms such as blood-ocular barrier and the lack of lymphatics. Kaplan and Sterling in 78 described immunization through anterior chamber created systemic deviant immune reaction. That is, when any pathogen or any allergen from the eye goes into the system and systemic circulation, there is no antibodies formed against it. That is the immune deviation that happens. Current understanding says that immune privilege is an anatomical segregation and a complex interplay of other active mechanisms, which we will see. These active components include immunological ignorance, peripheral tolerance to eye-derived antigens, and the immunosuppressive microenvironment in the eye itself. So the passive factors are blood-ocular barrier, deficient lymphatic drainage, intravenous drainage of aqueous humor, so it directly goes into the vein, reduced intraocular expression of the major histiocyte complex, both class 1 and class 2, and the fewer antigen presenting cell, be it from iris to retina, anywhere. The active components include cell surface expression of different ligands and soluble factors in aqueous humor such as TGF factor beta, alpha MSH, VIP, interleukins, and soluble CD95 ligands, and thrombospondin. So innate immunity is an antigen-independent reaction having immediate maximal response, which is not antigen-specific, and there is no immunological memory. These are derived from lactoferrin, lysozymes, defensins, complement systems, mannose binding lectins, all the pathological mechanism that is possibly there. In contrast, adaptive immunity requires antigen, which has to be recognized by the immune system. So it is very specific. These antigens are recognized by the presence of epitopes. That is very important for our understanding of anti-VEGFs, which is then processed by the system, and then there is an immune reaction which can be delayed too. This reaction is antigen specific, and the immune system creates a memory to the particular antigen. So that is one very important point to be noted, that there is a memory to be created, and it is rarely first type reaction. The immune response of adaptive immunity has been described by 4 mechanisms. Type 1, that is the anaphylaxis reaction, that is IgE-mediated immediate reaction, while type 2 reaction is performed by cytotoxic T cells via IgG or IgM antibodies and happens within few hours to few days. Type 3 and type 4 we will see. The immune response can also be divided based on humoral, that is the antibody-mediated, and cellular, that is the cell-mediated. So humoral response is via antibodies produced by B cells targeting extracellular microbes and toxins, which will be important for us to understand, interacting via B cell receptor, which can also recognize unprocessed antigens. In contrast, cellular response is very specific to, via T cells responding to intracellular microbes, their products, and tumor cells. So all the reactions that can happen to the molecule itself will happen through humoral response, while anything happening to the debris in the preparation, that will happen through the cellular response. So type 3 hypersensitivity reaction is a humoral response involving IgG antibodies, which forms a chain with the antigen and get deposited in the tissue. So this is very important, what we have proposed for brolucizumab also, and sir will be talking about it, that there is a formation of a chain that gets deposited into the tissue, and over subsequent time, if the deposition gets more, it can lead to occlusive vasculitis, which was a new phenomenon with brolucizumab. So these deposits attract complement, leading to neutrophil discharge, and the complete process may take few weeks to be clinically evident, as again seen in brolucizumab. In contrast, type 4 reaction, which we assume brolucizumab is having, is just because it was delayed. It was presenting 4 to 8 weeks. But it is, as we know, inflammatory response is the clinically evident immune response. So it takes time to get clinically evident. Cellular response, I think everybody knows it is, first there is an exposure to an antigen, there is a prior exposure that is required, and then subsequently the second reaction will be like an anaphylactic reaction when suddenly the patient will develop reaction. So this is one hypothesis that also holds value for brolucizumab, because it happens with second dose mostly, not with the first dose. And again, there is a preformed antibodies, which again we'll talk about, because it is a smaller protein. So it has preformed antibodies against it also. So now antigens can leave the eye via 4 gates only, which are lymph vessels of conjunctiva, anterior chamber angle, and the Slem's canal there, retinous venous circulation, and the choriocapillaries. The lymph node of ocular circulation is spleen. There is no lymph node in neck or anywhere. It is the spleen. So any antigen presenting cell initiate T cell maturation should reach the spleen. The peripheral tolerance to the antigen happens in the spleen. So let's understand some part of sources of immunogenicity. I think I have told some part, and then sir will continue with his talk on brolucizumab. First thing to understand is why does not all injected biologics, which essentially are foreign or non-self, induce an immune reaction? This is done by making the antibodies more humanized. That is, essentially leaving the epitope as it is and changing the rest of the things to become more human, so the body doesn't consider it as a foreign antigen. The humanized antibodies are tolerated by our immune system through the self-tolerance pathway. The molecule, however humanized, still are all immunogenic. The vehicle itself can carry cellular debris, degraded protein fragments due to oxidation, deamidation, glycosylation, and aggregation of such protein itself can cause debris. And they also carry endotoxins from the cell line. The injection technique itself can cause a reaction, as we have also published in an article that the silicon lining of the injection itself can induce an immunogenic reaction. The details of each component will be dealt by sir again in his talk. The immune reaction can be enhanced by localization and prolonged presence of the biologic in an increased concentration in the proximity of antigen presenting cell, and such factor may lead to inflammation. So if we are giving more amount of antigen very near to the antigen presenting cell, like in brolucizumab, we are having a very high molar dose. So that can also lead to inflammation. The antigenic site on the antibodies have been termed as idiotopes. This is a new concept that we are trying to push. It is not a new concept, but we are trying to push into the biologics segment. That is a formation of anti-drug antibodies. Anti-drug antibodies essentially mean when we are injecting a biologic, there is a small amount of immune reaction, and with subsequent injections, this amount of antibodies, ADS, keep increasing, and that may lead, that can be one of the factors that leads to either tachyphylaxis or intolerance or failure of the therapy in subsequent stages. So the AD are produced via T cells dependent pathway if the biologic is processed by antigen presenting cell, while few can directly interact with B cells to convert the B cells to immunoglobulin G producing plasma cells. These IgG ADAs development can be triggered by an exogenous human protein or by the failure of immune tolerance to the self antigen that can lead to overt immune reaction. The ADAs can be either binding or neutralizing. They can either bind to the drug and make them deposited in the cellular debris, or they can neutralize it and the drug won't have any effect. The new immunological debate that has been brought in focus due to retinal occlusive vasculitis, which has been reported following brolucizumab. While there have been many theories put forward about the pathway, including our group, the only clinico-pathological correlation was done from a vitreous sample taken from a patient, which majorly showed CD3 positive cells, which are immature T cells. There also has been some CD4 and CD8 cells and also rare B cells. So it looks like there is a complex interplay that is happening of type 3 and type 4 reaction that is leading to that peculiar reaction, that is the occlusive vasculitis, which was never seen before with the anti-VEGF agent. So over to sir. Thank you, sir, for this opportunity, and we will continue, sir. Thank you.
Thank you, Nilesh, for giving the overview of the immunogenicity, how it works. So predominantly means all the attendees, it might have been quite a complex talk, right? Because immunogenicity is complex. So means because we have time, so I probably, because we have industry leaders here, so probably means Manish is here. So means Manish is somebody, you know, who has seen Razumab journey from the beginning, and they had some issues in the beginning. Means Manish, I would like to have your comment on the endotoxin part, you know, which we dealt with, I think, second, means if you can come on the mic.
Can we have the
yeah.
mic there, please? Oh, thank you. So,
Again, when it's come to endotoxin, it's one of the most important parameter for any biologics. And there are certain permissible limits. Like if we talk about FDA limit is different, ISO limit is different. So like, especially what we have found that in our internal studies, at any point of time, if endotoxin is more than 0.2, it might lead to inflammation, which is very much aligned with FDA. Like there's it's not that you can say that biosimilar. Even for any product which is in being used in ophthalmology, there is specific limits. Like for IOLs, there are a limit. For viscoelastic, there are a limit. For you can say that dyes, there are a specific limit. And the limit for ISO, any limit which is being decided by ISO and FDA, these are the different limits. And the limits which is being given by the FDA, it is more tightened limit. So any product which is in much more aligned towards the FDA limit, of course the chances of inflammation is going to be subsided. And at the same time, the most important factor is that even at that limit also, the chances of inflammation might exist. The reason behind it, every patient is different. Every patient has got a different immunogenic, you can say that, response to the drug. Immunity is different. So like that is also important factor. It is like that we can't say that even at that range, the product is 100% reaction free, ADR free. We can't say.
So I agree. Means this is a very important point, because immunogenicity is all about, you know, how, means it does not just depend on, you know, how the drug is structured, but it also depends on, you know, how your body. Oh, Dr. Mangat is there. Sir, would you mind please coming in? Sir, please. Because we have missed Dr. Vishali. She had to go for, sir, please come on, sir. Please, I request, sir, please. It's an honor, it's an honor to have Dr. Mangat, sir, on, with us. He's very kind that he is in the session. He has been a teacher for all of us. I think he does not need introduction at all. Yes, sir. Honor to have you, sir. So as I was mentioning, immunogenicity is something that you cannot just control by controlling all the parameters that you have while manufacturing, because it's your body, body responds to a few things quite differently. So I think we have leaders from Lupin also. I'm not sure whether from Reliance. So Lupin means now your molecule is just approved just now. So Rennie Eyes. So what kind of immunogenicity tightening was done during the phase 3 for that? Oh, Dr. Natarajan, please. So it's good to have both of them with us. It's so kind from both of them. Yeah. Thank you, sir. Thank you for joining. So if from Lupin, if we can ask, because Dr. Vishali was not there, and I have just made it like Miami said, that introduction session that we were there. You know, yes. It's like industry session with because everybody wanted, that kind of. So we both were there, Dr. Natarajan and me were there. So in the opening session, that was the kind of unplugged session. The industry was with us, and we always feel with all these molecules, we learn so much from the industry also. So Lupin molecule is just going to be launched. So we would like to have some word, what kind of immunogenicity testing was done in phase 3, if you can comment on.
Basically, sir, we have done the overall phase 3 clinical trial. That is a double-blind phase 3 clinical trial, and which is done on 202 patients. In that 101 patient that we have taken for our ranibizumab, lupin's ranibizumab, and one patient was on an innovator's branch. So in terms of the overall immunogenicity levels, so we are almost equivalent to that innovator brand, sir.
Means, do you have any percentage to quote, or?
So there is only one patient which has been, because in the overall there are around 88 patients. So in that there is only one patient which has been come out with this. There is an immunogenicity reaction which has happened, but overall it was not.
So last time, what we were discussing before the conference, we should ask them to check for the ADAs also, because
Yeah,
it is
I
a
think
very minuscule percentage that they check for ADAs.
Okay.
So we just have a sincere request for future development of product that
So
ADAs
I
should
think,
be.
so means ADA, I think in all these international, we are part of some of the EM and FDA trials, that ADA has become a very important tool. So I'll take one comment from Dr. Dogra sir. Means in terms of now we have approximately 3 biosimilars. One is from lupin, means which would probably be coming in. One you have Resumab, and one you have from Reliance. So means at present, means do you see them from a different eye, or means what is your comment on that?
I think the way we, right from beginning, the way we worked, I think it's known to everybody. We are very careful. So that was the story even with Razumab. I think we started using it very late. And now once it is being used, I think it is used really left and right, because you develop that kind of a confidence after all those things happening. So we do get a lot of this thing from Reliance people that we should be using it. Nothing against it, the same thing. We want to look at how it is doing. Has it been used in more number of people? Because the question remains always with any biosimilar, if we have reaction or some problem, I think it has to be reported and it should come in the public domain. And that's how we build the confidence. So this thing for the lupin also, or any of the biosimilar, is same, that let's have a real good data down the line, or your users should also be very sincere, not that they should be. So that's where I think the bottom line for us is, and that's how at this time perhaps this Razumab is being used more and more, because the confidence building was because of the numbers which were reported across from various centers.
Very well said.
Yes.
I think, sir, I completely agree. Dr. Natarajan, you have any point?
No, I think I agree with Dr. Mangat, and same problem I had. And my patients could afford, they say, oh, why should I use the drug which is not internationally available? Why can't? So the problem was the same. Well, I think the beginning we all shared. So I think that's what we had a discussion in Fort Lauderdale also. Like when you have a standard drug, when you have a biosimilar, and what's the difference in the
True.
drug? And I think you also explained there the Avastin. The biosimilar Avastin is not a offline drug, and it's a
It's the innovator, it's
Yeah.
it's not right. So probably means with sir's comments and overall means it's not about just biosimilar. It's about any molecule which just which comes new, that we always take it slow, because that's what the lessons that we have learned, and just take it slow, and probably once you develop confidence, for example, the kind of confidence Resumab has given now, if you see the data from VRSI 2018 to 20, initially there were hiccups, but from 2018 VRSI data says that kind of usage it has just picked up. That's what means when me and Dr. Natarajan were there, means now US FDA has approved their first biosimilar in US, Canada, and UK, and 27 European countries. So we were proud to share our experience, that how our journey was, because there is still a lot of skepticism in overseas, that how they would place this drug, because means a lot of dynamics. It's a regional dynamics means predominantly. So means whosoever player is coming in, we have opened a group which is called Bio User Group. Bio User Group is kind of real world data that we would be collecting from Japan, because Japan also from January they started their first biosimilar ranibizumab started using from Senju Pharma. So overall from the West also, this is the feedback that we have received. More and more real world evidences that we have probably, that's where the confidence building happens.